And that was a better start anyways, right?
There's a better start, and the okay is not appearing. It's like apparently it's okay.
Because we
Once I
already
say
said
okay,
okay.
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 Break the introduction.
And
Stop.
by the way, yeah, by the way, we'll do the introduction, but it might just be recording on the continuation of the other one. You'll find out later.
I'll find out
Right?
later. Okay.
Everybody got all that? Okay.
We're going to start with a new introduction though. So here we are talking about OCD again. Dr. Jon
Ah,
Grayson is here, Mr. Zach Pacha. I'm Dr. Katy Manetta, and we're here to discuss a viewer's comments that I thought were very interesting. And, it's interesting because this was posted by a fellow therapist. And the therapist felt sort of silly about posting this question, but I don't find it to be a silly question at all. And I think it's not only very valid, but as I had mentioned, I feel like, if we ask 10 different therapists, we might get 10 different answers. Even amongst OCD therapists, we might get slightly different answers. And so I'm going to read the question and then we can discuss. All right. So from our viewer, Gina. Hi there, I'm an MFT and I'm hoping for some help with a client of mine. I feel sort of stupid asking because I feel like I should know how to handle this. My client is afraid of hurting himself or someone else. He avoids knives and other sharp objects and had his family hide them all from him. He stands and sits as far away from others as possible when there's anything sharp around. He's constantly self-monitoring for signs that he could lose it, and he Googles signs that he might be about to have some sort of a nervous breakdown and go crazy. I feel like I've been doing a good job of encouraging facing uncertainty, introducing proximity to knives, etc., and reducing avoidance, but he's still extremely fearful that he'll harm a loved one or himself or even a stranger. And he gets so agitated when these thoughts happen that he calls me on the weekend and locks himself in his car or his bathroom. He's now saying that he wants to go to an inpatient treatment facility, and I'm thinking that is a good idea because he doesn't seem to be getting any better.
So I have a couple of thoughts on it,
Okay.
probably
can
a
I say
lot.
one thing before?
Yeah,
Because um I want to thank the therapist for asking the question, and also it's not a stupid question.
not at all.
Honestly, I wish more therapists would be open about this. This is how people go about learning how to treat OCD. And at some point, all three of us knew absolutely nothing.
Mhm.
And for some of us, it was longer ago than others. Um, but yeah,
Thanks for that, Zach.
yeah, no problem.
I didn't
But
think
yeah,
Katie was that old.
I know, right? She looks
So
great though.
yeah, yeah. So you're right. I mean, it's not a stupid question, and actually, I mean, I do think there's some. I do have some ideas of what I think Gina might be doing that could be improved on, but I think it's really reasonable that she doesn't know that. If it is inpatient, there are only like actually two or three inpatient places I trust in the country, so I'd be happy to share them later. Um,
Mm.
I think the problem is, she talks about encouraging uncertainty. And so what Gina's you've learned is that's not good enough. I mean, I have to encourage uncertainty, but I won't start treatment until I have some agreement they would like to learn to live with uncertainty. I mean, obviously they can't accept it, otherwise that'd be cool, Gina. We'd be done today.
right.
But they can learn, and it is really scary and really difficult. They're seriously scared they're going to harm themselves or others. So, convincing them to risk living with uncertainty, I have to give them reason to risk the worst happening because living with uncertainty for whatever it is always taking the risk that the worst thing will happen. And my hope is to try to find a way to cope with it. So I'm not going to say to the client, you will never hurt yourself or others. You will never go crazy and do that. I will say, because it's accurate, having OCD in these thoughts does not put you at greater risk to do harm than to me. So I am just as likely tonight to go crazy and slice and dice my wife, Kathy. And there's nothing I can do to make sure I won't slice and dice her. The only thing I have in my favor, the only thing she has in her favor is it's a low probability, but
Right.
low probability events happen. So,
And John, I want to just pause for just 1 second because I want to just clarify one thing that you're saying that I think is so important, which is that, when Gina talks about that she's encouraging facing uncertainty, one of the problems that I've seen with other treatment is that they feel like exposure to uncertainty means exposure to the stuff that has to do with the obsession, meaning that somehow if they're around knives, if they're introducing knives, that is exposure to uncertainty. And the important distinction that you're making is that exposure to uncertainty doesn't have to do with proximity or knives. It has to do with embracing that ultimate feared outcome, the possibility, not the definite, but the possibility, introducing that possibility could occur.
Yeah, I'm suggesting to the patient, I'm figuring the odds are in my favor, but I can't be 100% sure. Just as the way, like, I am sure the client does not want to be maimed, paralyzed, and disfigured, but if they go in a car, they risk that happening. And their brilliant plan is, well, I hope it doesn't happen, and I'm not dealing with it till I'm bleeding out, crushed under the metal. So we take that, all of us take that risk. I get to find out later that I lucked out. I didn't die again. So what's going to convince the client to take that risk? Because there are a bunch of things. One, I think it's absolutely crazy to say avoiding proximity to knives is going to protect anybody. Because you know what? If I go crazy, fine, I'm running out of the room and I'm getting the knife. Now, the patient has them lock them in the door, so that's cool. But that's only if I go crazy at nighttime. What about the rest of the day when you can walk around, go crazy? Like really, if I'm going to go crazy, I need to be locked up all the time. And I suspect some of the patient's desire to go inpatient is avoidance.
Yes.
Now, mind you, they're going to, the patient may be upset if they go to a good treatment center. That yes, we're going to give you a knife. And the reason I only have like 2 or 3 I like is there's some that really emphasize the uncertainty part as opposed to just treating exposure as uncertainty. So we're trying to convince us, so one thing is your rituals don't work. If you're going to go crazy and start stabbing and killing, as soon as we let you at the room, that's it. It can happen. And it's not feasible to keep you in the room 24/7. How is it wrecking your life giving into OCD? And we can just find a multitude of ways that their lives are being wrecked. Just briefly, for free at a site, freedomfromocd.com. All the forms in my book and the 2 forms I'm going to mention are available for free download. So I have 2 forms, ERP motivators. One is, in what ways has OCD hurt me? And it gives a few categories. It's not a thing to score. It's literally for them to write out in detail, not like I've been humiliated, but how have I been humiliated? What have I been late to? In what ways? And there's another form, what ways have I hurt my family? Because obviously this person is causing a lot of harm. So we have to take the risk that I might do that.
Different kind of harm, though.
Different kind
Different kind of harm.
Right. But undoubtedly.
The irony of OCD. I don't want to harm people this way, but inadvertently, I could be harming them emotionally.
The family having to deal with, this family member going and locking themselves in a car, locking themselves in a room.
Yeah, and the family, of course.
And the fear associated with somebody saying, put away all the knives.
And of course, if the therapist, I would not start treatment until I have an agreement. I'm willing to learn and take the risk of living with uncertainty.
Right.
Because as she has found out, it doesn't work. So the problem was and I think the art of therapy is getting that initial, agreement. Now, I think the vast majority of patients, that's 1 to 3 sessions for them. Like, oh yeah, I'd have no choice. I've got to do that. I had a client for 2 or 3 months before he was willing to take the risk of his OCD coming true. And we just spent lots of sessions talking about how the rituals they were engaging in were purposeless and couldn't do anything. So finally they agreed, and that's when we began to do exposure, and they recovered and did really well. So can I get them to that point? How many arguments can I make? The arguments are like, sorry, these thoughts you're having about hurting people, they're normal thoughts. The problem with you is you don't want to have them. If you give somebody a little baby to hold, it's a normal thought to think about killing the baby, because everybody's going like, it's so cute and little. Look how helpless it is. The thought behind that is, its life is in my hands and I could hurt this baby. And the reason it's not common knowledge is, first of all, most people, if they have the thought, they just goes through because they're not worried about it. Another
Right.
group just go, weird thought, I don't care. And the third group who realize, oh yeah, that's a real thought I'm having. But we all have enough social skills to know not a good thing to say to the new mom. The
Right.
baby's little. You realize I could kill this kid? Like, we don't have to say that. My daughter-in-law, who knows what I do, when my grandson was born 10 years ago, despite she's heard me say stuff like that, I did not hold little Jack and go, and right, it's like I could kill Jack. Like, I knew that wouldn't be a good thing to say.
Just
Um,
just
And I
omit
won't
that.
be saying it in about a month when my wife is due either.
That's
yeah,
right. You're gonna keep that to yourself.
yeah, yeah.
Oh yeah.
I want to go back. I want to go
So,
back
so
though.
wait, wait,
Oh, go ahead. Sorry. Finish your point, John, and then we must
as
discuss.
if,
He's
as
he's
if I
doing it.
would finish.
I know.
So, so I have to go through these arguments of why they would do this, and the key is like, you're doing all this and you could kill someone anyway, and you can't even kill yourself because that means other people in your family will feel they'll feel guilty forever. And if they get depressed, the fact you killed yourself would be a good reason for them to kill themselves. So you'd be responsible for their death. So the only thing you can do, and this is the one good thing about OCD. Some problems, if the person gets better, it hurts people. Like, you're in a really crappy marriage and you need a divorce, it helps you, and it might be long run good, but it's a lot of stress. OCD, if I get better, the whole family gets better.
Yeah.
Now, I think this therapist also probably needs to talk to the family
Mm.
and
Mm,
reach some agreement about not not
Not
maybe
accommodating.
not accommodating this much. I mean, they can't do full scale non-accommodation.
Right.
That would just blow the patient. But this level is definitely not useful. And so I would ask to talk to the family because obviously I need the patient's permission. And if I'm not allowed to talk to the family, I might say to the patient, your family is making you worse because of what you're doing. I have to, we have to work in this together. If you're not going to allow me to talk to them, you're not willing to learn to live with uncertainty right now, and that's
And that's
okay. We'll
usually
try to
and
talk you
that's
into it.
usually it, right? I mean, that's when patients say, no, I don't want you to talk to my family about all the accommodating that they do. It's typically that they're not ready yet. And so usually I wait for the patient to be very ready. And like any request that we're going to have with the family, I get the patient's agreement ahead of time that this is how we're going to proceed. And it might
Yeah,
be that they say, okay, I am going to stop asking my wife for reassurance. I am going to stop
hmm
locking myself in the bathroom, but we're still going to lock up the knives for a while, right? And so, it might be in stages, but having the patient really agree and be there in the room with me when I'm giving these new set
yeah,
of instructions so that the buy-in is there and they're prepared for the
I
change.
agree. And usually I'm very cautious about allowing family in because if somebody allows the family in, the family gets happy because they can help. And then if they back down, the family gets really angry. So I'm always kind of cautious. Like, if we're letting them in, you've got to really be
Got to be ready.
committed to that.
Yeah.
This kid sounds so severe that I want to talk about, ways we're going to start to remove it, not at the rate I would in regular treatment. I could have some accelerated rate. I just want ways in which we're not going to do, not do it at this level.
Right.
Um, and I don't know if the family's scared to death that like he's going to kill us.
Right. Yeah.
I
Sometimes they
mean, it's
Yeah,
are.
like,
because
you
the
know,
average person doesn't know about OCD.
No.
right. So, it's like, oh,
Yeah.
we're betting your lives that he won't.
And people with
Um,
OCD, this is the other challenge we run into, right? They can be very convincing, right? When
yeah.
they're in the throes of whatever
Well,
OCD.
you're really anxious, but this is, the kind of crazy you're talking about is a different kind of crazy. Now, it could happen.
Yeah.
It just happens that having OCD doesn't put you at risk for this one. So, um, so we're going to act like it's OCD, and hope that it doesn't come true. And if you do harm, I hope that we, catch you before you do serious harm. Um, but the thing is, your rituals don't work
Right.
because you can always go crazy, you can always break down the door, and I'm really hoping your parents don't agree, like, let's put you in a straitjacket every night so that you can't move.
Right.
In
So I
terms of
want to,
harming,
I
And
do
in
want
terms
to
of harming
shift.
yourself, you can always
Yeah,
bang your head into a wall. So I don't
that's
know why
right.
knives, so it's like we
Lots of
have
ways to harm.
yeah, we're going to have to
Even
work
if
Screwdriver.
we
on
get rid of all the knives, there are the pitchforks, especially if you're in
in
Iowa,
the
right?
bathroom.
Well, no, and then there's the
Oh,
pitchforks outside because Zach's in Iowa, and I bet there are a lot of pitchforks that people use there. Am I right?
yeah.
You could kill
Don't
somebody
be.
with
I got a feeling you're not gonna go to Iowa anytime soon. So
probably not.
okay. You won't be able
Anyway,
to find out if it's true.
And
I
you know
know.
what? And where he's going in Minnesota, we replaced
I'm
pitchforks
in
with something
Minnesota right
worse.
now, by the
Ice,
way.
I know, ice
Okay.
picks,
Well,
which are much
Minnesota
more
is a big
portable.
pitchfork state too, I think.
Ice picks,
Ice
snow
picks.
blowers the size of cars. Oh yeah,
That's right.
it's
All right,
it's
so I
great.
want to go back to another
Okay.
important thing that I think we need to address, and it's this question of an inpatient treatment program. And of course, there is a time and a place, but what I want us to discuss, which I think is an important thing to consider, is sort of cost benefit, because the biggest problem that I have with inpatient treatment for a patient like this is that it really removes so much of the risk, because even if they introduce knives in the treatment facility, then the person can say to themselves, well, these are all trained professionals. And so if I'm going to, do something here, they're all ready for it. They're going to tackle me. And so there's safety built in, and it's like it's kind of
Unless
like,
they tell them to leave the facility to go do their exposures, which they
unless
But I
should
also
do.
I also feel that we can assure the patient with a high degree of confidence that the majority of staff are not skilled in self-defense and know how to take them down.
we
You know,
can, but
and
but
and, and because right, what we would do,
but it does remove
what
family.
we do is I would have you right sitting in the session holding this at my wrist.
Hmm.
And so that, if you suddenly go mad, you can cause a lot of blood to come
I
out of me.
But
So
then you're
I'd
in
do
a
that.
hospital, John, and people can intervene very quickly.
it depends on how quickly and how many stabs they get in, how savable I am.
That's true. And
Time
so
out.
I agree that there can be uncertainty in the hospital, but
I
I
and
Yeah.
I and I
do,
and I don't think this person's idea of the hospital, I don't think they'd be comfortable when it's like, oh, we're going to give you knives. Now, what my big concern is, most, there are a ton of programs that claim to treat OCD.
mm-hmm,
Like
There are a bunch
therapists.
that don't do it well. Yeah,
mm-hmm,
like therapists. There are a bunch that will talk about dealing with uncertainty, but haven't done the finer points of uncertainty. So, I said this woman is really on the right track. It's just that I can't really start till I've convinced them of that. And God
right.
knows how long that's going to take. So same with inpatient units. So the few that I really like, I know that they will help the person deal with uncertainty.
Telling me, John. All right. So going back to this issue of inpatient treatment, though, I do think that it's important to to discuss with the client what their reasons for going inpatient are. And with a client like this, if their motivation is that they perceive that going to the hospital is somehow going to increase their safety and reduce the risk of harm to others, then that might not be the best reason, because the truth is, whether they're in the hospital or whether they're outpatient, we're still approaching the same problem, which is that they're gonna at some point have to embrace this idea of risk of
which
the feared outcome.
which brings up 2 points. One, I would let the client know that if we're going to send them to a good inpatient program, they're going to be saying exactly what I'm saying, and they'll be playing with knives, and so there is not going to be greater safety.
Right.
And the one thing is, actually, they will not lock them in the room at night. They will not tie them down. So they will have access. And as we pointed out earlier, you know, cutting off your access from knives doesn't mean you're not going to try to kill people a different way.
Right.
So and you will probably not have a private room. So you've got a roommate to kill. So that's first of all, the hospital's not going to be safer in a good program.
Mhm.
We can talk, to her separately about the hospitals we think that are best. But the second issue is, and this is kind of odd, the person has to be good enough to go inpatient. And what I mean by that is, um, a client can defeat an inpatient program because they can't make you do anything.
Right.
Mhm.
So if they're going to go to
Yeah.
the inpatient program with the idea that I'm going to be willing to take all the risks. I'm going to risk that maybe I'm going to kill someone there and I'm willing to go in, that's fine. But if they're going to do all this there, then they're going to spend a lot of money fighting treatment the whole time. Now, the better inpatient programs, they're going to at least be arguing the same thing we are, which leads to the third form of treatment, what I like to think of as the treatment of last resort. And treatment of last resort might be that we'll get them better enough to go inpatient. My version is strategic pressure. There's a program, space program, um, which as near as I can tell, it's kind of a bunch of what I've done with strategic pressure in a more formalized, salable way, so you don't have to talk to me how to do it. But it's like how we're going to then stop treating the client and start treating the parents and find ways to gradually introduce them to their worst fears and make it inescapable. Now, I can't just do that. So
Right.
it's an art to do that. The idea of like just stop doing everything and stop giving in. That's like overwhelming. And also, a program like this is treating both the client and the parents because
Now,
they
wait,
have
can
shown.
I point something out? So we don't know
Yes,
that this is a juvenile client living with
That's
parents.
true.
This could very
So
well
maybe spouse.
be a spouse
Yeah,
or a father, etc.
okay.
whatever.
Now you're
Yeah.
right. I'm assuming because
Now,
the
but can
program
I do want
yes,
to ask you a question though, John, because I'm very familiar with your strategic pressure plan. I actually took copious notes one time when you and I were consulting on a case. And so I actually trained some of the people that I work with on strategic pressure because I think it is so useful. Would you use it if this situation was a spouse?
I can. I can only use this on a child or adult child
Right,
living at home, not paying rent.
right,
So I cannot use it on a spouse because I literally don't have the control. Because it turns out an adult child living at home, not paying rent, actually has no rights to the room.
right,
So I can do things as a parent that a therapist can't do.
right.
And so we take a way to gradually introduce those things. If it's a spouse and I'm working with the family, I'm going to spend a bunch of time working with them, but I am going to suggest that if they're not going to change, do you want this to be the rest of your life with this person?
Right.
And if it's a spouse and you have kids,
Yeah.
is this, like I know it's painful. So I'm going to consider that with the family but also critically say, do not threaten this.
Yeah.
And the reason for not threatening is you cannot say it unless you mean it.
Mhm.
So
Hmm.
if you're saying like, I need to see change unless or I'm not going to stay, you actually have to mean that. Otherwise,
Right.
it's an empty threat. That's
Yeah.
not, but I'm saying at a certain point, I would want to consider that.
Right.
Because if the person's unwilling to change, um, this could be my life forever.
And just to go back to the conversation we were having about inpatient program, it sounds like sort of as we talk about it, when we think about an inpatient program, as opposed to it being that the goal is to keep the person safe, because I have a sense that that's what Gina was asking us, right? The goal
Maybe, I
is
don't know.
not, the
Yeah,
goal
we
is
don't know.
not to necessarily keep the person safe or keep the family safe, right? The goal is actually more intensive treatment. Am I
Yeah,
right?
I have faith in Gina. I felt the way Gina was asking it. I hope I'm right for Gina's sake, because she'll like that somebody had faith in her. I felt that her issue was I'm not getting anywhere treatment wise, so I need some other higher level to do that.
Right.
And I don't feel I am with her that I don't think IOP would even be enough.
Yeah.
Mind you, finding an IOP I like might be hard, but I feel like, but there still hasn't been this first issue. The only other issue that might be really important that she has not explored, but I'm assuming it has been. I'm assuming this person is on meds.
Oh,
Mm,
that's excellent point.
You know,
Excellent.
yeah.
I mean, because meds, I said, on the average, meds alone, 25 to 50% improvement, which leaves a lot of people seriously disabled with OCD.
Right.
So, they're still stuck with us.
Right.
But it can be the difference between the person being more open to hearing us versus not. So I'm assuming they're on meds. If not, that would be my next battle. And again, there's certain areas where, I mean, if the person is just refusing everything, it's like, you're not letting me help. I'm
Right.
okay with trying to discuss the difficulty of coping with uncertainty and convincing you. But OCD is a learned and biological problem.
Right.
And I can see the individual being afraid of meds because, right, there's the myth of,
I'll
SSRIs
go
cause
crazy.
suicide and kill, but
Yeah.
the actual truth is some people can be too depressed to hurt themselves, and as they get, better, they get enough energy to hurt themselves, but not enough to be better. But I personally haven't seen it since
Me either.
1978. I'm
Yeah.
sure it has happened somewhere, but it's a low probability event along with, the patient going crazy and killing their family.
The other interesting phenomenon with medication, I don't know if you guys have encountered this, is that these medications do work to a certain extent, and part of what seems to happen is that people lose their hypervigilance. Like they don't lose it completely, but they will often come in sort of reporting that they feel like they're not being cautious enough, or that they're not being careful enough, or that they're not paying close enough attention to the details. And when they feel that, I've had patients that have actually objected to medication because they don't like that sensation, like
Well,
they're
right. With
slipping.
but by the way, I wouldn't blame the medication on that one. I would say it's a combination of medication and good therapy from the therapist.
Mm. Oh, are you blaming me?
I'm complimenting you.
Oh,
Yeah, it's
okay.
kind of the opposite.
Yeah. Um, I didn't know Katie was so paranoid.
Thank
It
you.
was the whole webinar experience.
I
I got
know.
to know her a lot better.
Yeah.
So I think, right, but with harm OCD, right, that's not uncommon that the initially getting better scares them because, oh my God, I'm not scared about killing people, so now I really will kill people.
Yeah.
So I'd
Hmm.
like to warn them of that that this is going to happen to you, and it's a good sign. And if you might kill someone, but you'll be my first.
Yeah. Do you usually say that?
Yeah, because it's true.
What? Why wouldn't he?
I know that's true.
I'm not
That's
saying they
like,
won't do it. Just they'll be my first.
yeah.
I don't know if I've ever actually said that before. Let me think. I don't know if I've ever actually said that,
You
but I'm
know.
going to put it in my repertoire now.
Okay.
I'll put it in my repertoire.
I'm glad the three of us could help someone today.
Right.
When all else fails, at least we're enjoying
Right,
ourselves, right?
Well,
right.
a little summary, like I think all of us think the Gita said her name. Yeah, she's probably on the right track.
Yeah.
Yeah.
The client clearly though, like what John was saying, he's only willing to do so much. So whether it's I'm only willing to accept a smidge of uncertainty or 10%, that's not going to do it.
Hmm.
Hence
Yeah.
why what John was, saying about there's just you got to have more buy-in.
Yeah.
And I
So,
think Regina might, she may or may not need help,
yeah.
is this idea that I'm going to help get compliance on living with uncertainty. It's it's just like, when we say that when I hate it when therapists are like sit with your anxiety. And I hate that because not that I think the idea is wrong, but unless I'm telling the client how to do that and what are the steps you need to take to be able to do it, it's like it's like saying to the client, you worry too much. Oh my God, thanks. Now I know what my problem is. I'm going to stop worrying. So
Or just stop it. Here, I
That's
got our
right. Just
plug-in.
stop. There we
so
go.
getting
Okay.
back to Gina,
Yeah.
we're saying, we're saying to you, you need to work on this getting compliance, but I think for every presentation of OCD and different clients, there are different arguments to use to help get the person to that. And she might find that it's an area where she needs some additional help, above and beyond writing the forum. Because, I'm saying do this and I can give, non-specifics and ideas. Um, but it may be that it would be, she'd find useful to talk to somebody about how to get that compliance and what are the arguments that are going to work best with this client. And this client, of course, is a particularly severe one. I don't think the client's hopeless for it. Um,
No.
but I also don't know the client. So, she has to fail first doing this, but the client may be changeable or not. I think if the client's not taking meds, I think the odds of making a dent go way down. And taking meds, it's a definite maybe.
So we're all in agreement that medication evaluation, if that hasn't happened already, that's definitely in order. And I think we're also all in agreement that it sounds like that perhaps there needs to be sort of a downshifting kind of that happens here. And, not
To
necessarily
get them ready for therapy.
right. Yeah, that
Yeah.
we have to prepare better for the experience and really assess the willingness to accept uncertainty about his particular feared outcome, which is about harm to family members or even strangers or maybe himself.
Yeah. And not surprisingly, I have something else to say.
Oh, that doesn't surprise me at all.
With medication, in case they're saying no and they've already tried medication, I think we need to make clear, a few things. One,
Yeah.
25 to 50% improvement, that leaves a person pretty, still needing us. So if they're basing it on the idea they didn't get better from medication alone, no surprise to us. So
Right.
that's fine. Secondly, I find with medication, I mean, sometimes it does quiet thoughts a little bit, but that's kind of unreliable because the learned part of OCD is so powerful. But the way I tell if medication is working in general is it works way better on the depression. So if I see a reduction in depression, then I know that the meds are working, even though the anxiety and OCD seem the same. So,
Makes sense.
so if they're not, past attempts with medication and failure don't tell me anything. And of course, it's the issue which a shrink would figure out, psychiatrist. Was it an adequate dose?
Right.
It's on the average, people with OCD take higher doses.
They do.
Mm-hmm.
They absolutely do. Yeah,
And
I've
an
seen
actual
doses.
good faith trial, like
Right.
taking it the way you're
More than
supposed to
more
for
than
X
1
amount of
week.
times.
That's the other thing. Yeah,
Sporadically for a
some
period of
folks say
time.
it didn't work, but they took a sub-threshold dose for 4 weeks, and that's just not enough. It's not long enough. It's not going to be a high enough dose. It takes a while to titrate up to those doses that are likely to be helpful for OCD. And so, yeah. And then also, like you guys are saying, right? The magic in treatment is the combination of the two, particularly for severe cases. And so, and I don't know if you guys have ever experienced this, but I have, and we can sort of share this with Gina and other therapists that are treating this. I can feel it when a person gets to the right dose of medication. It's really very noticeable in terms of,
Even if they're suffering a lot.
yeah, even if they're suffering, even if they're still suffering, even if they're just even the earlier stages of treatment, et cetera, it's remarkable.
And I don't know about this kid or guy because of the level of severity. I mean, I often tell clients, because it's true, the very first sign of the meds working is if the person comes into me and says, I don't know if I feel a little better. I don't know if it's really working or not, or it's just my imagination. If they say that to me, it's like, okay, that is the beginning,
Right.
With that doubt, but so that's like my first sign when they I don't know if it's really, maybe.
Yeah.
That's
Or
Maybe I feel a little something.
I had a particular time of the day when I noticed I wasn't quite as fixated on the problem, and I thought, and that immediately alarmed me, right? So sometimes we hear that alarm, right? I wasn't thinking about it so much. And then I thought, oh boy, this is something must be wrong. Are we sure everything's okay? And that usually means I'm like, oh, look, medication's working. Yeah.
Okay.
So any sort of final thoughts that we have about this particular case?
I feel like, and maybe at some point we should do something like this live, because I feel like the next set of questions I would maybe, the next more things I would say about this were if Gina were on, she might then have a, relevant specific question like, well, what about blah, blah, blah? And
I
we'd be
agree.
able to respond to her. So I
And
think
so
let's move to a live format next time.
we are going to.
Pressure's on.
We were going to try for that today, but unfortunately, our the
We did try.
technological.
It just didn't
You
quite
know
work.
what's great?
We did
I just want to
try.
say, I was just trying to set that up as like a future thing, as
Yeah.
if we just thought of it. And you just like completely blew that, Katie.
Yeah.
I'm-
Well, and
I was going like,
then you blew the
I think
fact that we
obvious.
screwed up, which is a good thing to model for people because you
That's
I
can
don't
right.
admit
mind
your
screwing up.
mistakes
Yes.
and get better, right?
That's right.
But in terms of, like, oh, hey, we're going to do this live in the future, like advertising and everything. But you just
I know.
set it up that like,
I
okay,
did.
yeah, we kind of bumbled it, but like maybe next
We
time.
did bumble it. I was live for a good solid 30, 40 seconds, and neither one of you were. So I just want to point that out that in
No.
terms of
Yeah,
our level of
because you
success
didn't
with going
invite
live,
us in.
I tried. I
Yeah, yeah,
tried. I'm going
yeah,
to try harder next time. We're going to
yeah.
figure it
John
Try
got
out.
really
horses.
lonely. Uh,
All right. So thank you very much. As always, we welcome questions on our YouTube channel, and we really enjoy responding to viewers' questions. And so feel free. And there really are no stupid questions when it comes to this treatment. I think the biggest mistake that most people make is not asking questions when they're in trouble in their own treatment or when they're in trouble in the treatment of one of their clients, that they feel like I should know this and I don't want to ask a question. It's always better to ask, always better to consult, because you can really help yourself and help your client at the same
And
time.
there is no therapist, no matter how skilled,
Yeah.
who doesn't ask friends sometimes, like, hey, this is a hard one. Got any ideas? So,
Absolutely.
um, we don't have any perfect therapists,
Yeah.
I hate to admit.
Just as proof, right? I mean, I have consulted with both John and Zach many times on cases. And so, yeah, we consult.
Same.
Good therapists consult as a rule.
mhm.
Okay. Thanks very much. Thank you,
Thank
guys.
you all.
I'm going to
Thank
stop the
you.
recording now.